The webinar will start in 1 minute. Welcome to the webinar, How to Use the CARE Toolkit, a 4-step process to detecting cognitive impairment and earlier diagnosis of dementia, developed by the Gerontological Society of America and supported by an independent grant from Merck. This webinar is being recorded and will be posted on the GSA website. A copy of the slides and the recording will be distributed to all attendees shortly after the program concludes. A question and answer session will immediately follow the live presentation. Attendees' lines will be muted throughout the webinar. However, we will be accepting questions through the question feature accessible on the bar on the right-hand side of your screen. My name is Karen Tracy, Senior Director at GSA, and your moderator for today's program. We have a fantastic lineup of speakers today, Richard Pertinsky and Katie Maslow. Dr. Richard Pertinsky is Professor and HealthNet Endowed Chair in Geriatrics and Gerontology at the University of Connecticut School of Medicine. For more than 25 years, Dr. Pertinsky has conducted research with community-based partners with the goal of improving care systems and health-related outcomes for older adults with dementia and their family caregivers. He has served as the chair of the GSA Workgroup on Cognitive Impairment and Earlier Diagnosis since 2014. He presently serves as Principal Investigator for Translational Studies funded by the NIA, and the Patient-Centered Outcomes Research Institute, designed to test in-home, team-based interventions targeting older adults with dementia, depression, and delirium, and their families. Dr. Pertinsky received his PhD in sociology from Brown University. And Katie Maslow is currently a visiting scholar at GSA. She participated in the GSA Workgroup on Cognitive Impairment and Earlier Diagnosis from its inception and was the primary author of the toolkit we will be talking about today. Katie also co-chaired the recent National Research Summit on Care, Services, and Supports for persons with dementia and their caregivers. Prior to joining GSA in 2016, she was a scholar in residence at the Institute of Medicine, where she worked on studies of geriatric mental health, cognitive aging, and advanced dementia. She previously conducted care-related research and analyses about cognitive impairment, aging, Alzheimer's disease, and other dementias and coexisting medical conditions at the Alzheimer's Association and the U.S. Office of Technology Assessment. Let me review our webinar agenda. Dr. Pertinsky will start by providing information on why and how the CARE Toolkit got developed, and Katie Maslow will then provide a deep dive into the elements of the toolkit, how to navigate the kit online, and to review questions you should ask yourself as you embark upon using the kit to enhance your detection of cognitive impairment and diagnosis of dementia. We will close out the program with a period of questions and discussions by our faculty. Let's go ahead and get the program started. Dr. Pertinsky, you may unmute your phone and begin, and please let me know when each slide is to be advanced.
Thanks, Karen, very much. Hello, everyone, and thanks for participating this afternoon or this morning in case you're in a different time zone. So we can go with the next slide, please. So just to give some quick background why we embarked on this project. So the estimated number of people with Alzheimer's disease in the United States is expected to grow dramatically over the next several decades. The black line on this graph shows for everyone age 65 and older in the United States, the millions of persons with dementia. living at any one time. So the slide shows that about where we are right now in the year 2017, more than 5 million Americans are living with Alzheimer's disease in the United States. By the middle of this century, there will be triple that number, really almost to about 14 or 15 million Americans living with Alzheimer's disease. Now, it's important to point out that Alzheimer's disease is only one type of dementia. Dementia really is an umbrella term that is used to describe a range of symptoms associated with cognitive impairment. And Alzheimer's disease, according to the best studies available, makes up somewhere between 50% and 75% of all types of dementia. So if you add other types of dementia, such as dementia due to strokes or vascular dementia, also dementia with Lewy bodies, and frontotemporal dementia, and then there are other kinds, you could come close to doubling these figures that are shown on this graph when you want to think about how many Americans are living today with any type of dementia. Next slide, please. So really, regardless of the type of dementia, these are some of the most common hallmark cognitive and behavioral symptoms associated with dementia. Memory loss affecting daily life, and in Alzheimer's type dementia, memory loss is almost always the first or cardinal symptom that older person would present with in the office setting. Other symptoms include, and all due to a cognitive decline in the brain related to brain pathology, include difficulty completing familiar tasks, confusion with time or place, having problems with finding words in speaking or writing that did not exist before, misplacing things, but misplacing things in a systematic way and in a way that really does impact activities of daily living, particularly withdrawal from work or social activities, changes in mood and personality, and this is where there could be an overlying depression along with dementia. And then as dementia progresses, which really means as the pathology in the brain continues to get worse, other symptoms, often called neuropsychiatric symptoms, could develop in people, and the individual course of the disease is highly variable, but these problems can include wandering, agitation, and other behavioral symptoms. Next slide, please. Dementia is not just a disease of the person themselves. It is also considered to be a family disease because dementia does have a tremendous impact on families of people who are suffering from dementia. There are several reasons why this is the case. First of all, there is great uncertainty about the disease process and how to prepare for the future. So when a diagnosis of some type of dementia is made by a physician, there isn't a clear course for the disease. In some people, the disease progresses slowly, and in other people, the disease progresses more quickly. But uncertainty is really the common characteristic. So families, along with the person with the diagnosis, are really left wondering exactly when they should start preparing for the future and what resources might be available to them to prepare for the future. Also, as dementia symptoms progress in the person with dementia, families assume greater decision-making responsibilities on behalf of their family member, and also they assume greater hands-on care responsibilities, such as starting to take over things like money management or grocery shopping, and then ultimately more personal activities of daily living, such as bathing or helping the person get dressed. Because of these new responsibilities that families are faced with, there have been more than 2 decades of literature, of studies in the gerontology literature showing that family caregivers are at increased risk themselves for physical and emotional health problems compared with non-caregivers. So it's important to think about not only the person with dementia, but also the family member or any family members who are loved ones of the person with dementia when thinking about how to approach caring for patients and families affected by dementia. Next slide, please. There's also been a considerable amount of literature over the last 20 years that have shown that there have been a lot of gaps and barriers to detection of cognitive impairment and diagnosis of older patients in the primary care setting. So what this means is that there are many patients who go to the doctor, and it might take a very long time for conversations about cognition to come up and for the whole disease process to be unraveled and talked about. And this was one of the many reasons that our work group was formed, was because of these gaps and barriers. However, it's essential, I cannot underscore this enough, for more timely detection of cognitive impairment and diagnosis of dementia as we go forward. Increased detection of cognitive impairment is really the only way that we could begin to increase the number of people who get an accurate and timely diagnosis of Alzheimer's disease or other type of dementia. Why is it important? It's primarily important because there are a lot of supports in the community that are available to help patients and families. We all know that there's not a pharmacologic cure for Alzheimer's disease, but there are a lot of non-pharmacologic or non-drug interventions that are available in the community now to help patients and families. But a diagnosis is needed in order for those services to be made available to patients and families. And that's why it's really very, very important to make a diagnosis as early as possible when it's appropriate. Next slide, please. So with all of that as background, going back now almost 4 years ago, in early 2014, the Gerontological Society of America convened the work group that we're talking about today and that I chaired, to summarize efforts that were currently underway at that time by a variety of national organizations, whether they be governmental organizations or other organizations, to identify evidence-based assessment tools for detecting cognitive impairment. And at that time, the Medicare Annual Wellness Visit was a relatively new benefit as part of the Affordable Care Act. And so the work group began by thinking about how the Medicare Annual Wellness Visit could be used as a springboard for more widespread use of evidence-based cognitive assessment tools by primary care providers. In fact, as part of the Medicare Annual Wellness Benefit, one of the tasks that is supposed to be done is to detect cognitive impairment. However, there were really no tools that were really focused on which types of tools should be used in the primary care setting. So next slide, please. So this tells a little bit more about the annual wellness visit. All Medicare beneficiaries are entitled to annual wellness visits, where this notion of detection of any cognitive impairment is a mandated component. And this presents an opportunity to increase the use of evidence-based cognitive assessment tools to fulfill this mandate on a universal basis. But as I started to say earlier, no specific evidence-based assessment tools were mandated in the annual wellness visit legislation. So as part of its charge, the work group reviewed other efforts that were started at the time that the work group was formulated to begin to identify such tools. And as you'll be hearing later from Katie, the toolkit includes a lot of these tools. Next slide, please. What the work group did was designed what we're calling the KAER or CARE process to illustrate the patient and family flow from the Medicare Annual Wellness Visit or other office visits to the primary care provider through the referral to post-diagnosis community resources. So even though our original mandate was to look for cognitive assessment tools that physicians and other primary care providers could use, we rapidly realized that it might be even more important to talk about how that step of doing an assessment for cognitive impairment could be fit into a broader process that any older adult visiting the physician might go through over the course of time. And that's really what the KAER process is from a conceptual point of view. So we finished the first bulk of our work in January of 2015 when we released a report, which is available at the website that's shown there. And what we did was we recommended actions for primary care providers related to the KAER process in that report. So what I'll do is just briefly introduce these 4 steps, and then Katie will be going into them in much more detail when she describes the toolkit. So the first step is the K, which stands for Kickstart the Cognition Conversation. And what this means is that when an older adult visits the office, for example, as part of the annual wellness visit, or again, it could be at another office visit, it doesn't have to be the annual wellness visit, that the doctor should discuss brain health and begin to incorporate discussions of brain health into their routine practice with their older patients. Because even though patients may be presenting with absolutely no signs or symptoms of any kind of cognitive impairment and they don't present with any worries, it's a good time to start talking about brain health as early as possible when the older adult is making a visit in the office. Also, as part of the case step, the primary care provider could observe for signs and symptoms of cognitive impairment and listen for older adult and family concerns about cognition. Oftentimes, family members do accompany their older relatives to doctor visits, and it happens more than infrequently that family members could introduce a concern as well as the older adult introducing a concern to the doctor. So that's the K step. The A step is to assess for cognitive impairment. So this would be the step at which, for those patients who are symptomatic or are showing complaints of memory concerns, conduct a brief cognitive test and other structured assessments to detect cognitive impairment. And then the third step, which is the E step, is evaluate for dementia. So that's the diagnostic workup. So if as a result of that A step, cognitive impairment is detected using one of the cognitive assessment tools that are in the toolkit, the patient should then should undergo a diagnostic evaluation, a full diagnostic evaluation. That could either be done by the primary care provider if they feel comfortable doing a complete diagnostic workup, or a referral should be made to specialists, such as a geriatrician or a neurologist or a geriatric psychiatrist, for example. And then finally, the fourth step, which is the R for refer, this pertains to referring to community resources. So if dementia is diagnosed, refer the older adult and family for community services and other resources. And this is a critically important step. So the doctor's involvement should not end with, yep, it looks like Alzheimer's disease, and please come back in 6 months and we'll see how you're doing. This R step of linking the patient and the family to community resources should be as important a part in the KAER process as the K and the A and the E. And so what are the desired outcomes from this whole step would be better patient-related outcomes, better family-related, health-related outcomes, so that even though they're living with dementia, as much information as possible and support as possible could be routed toward the patient and the family. That's really the end goal of the KAER process. Next slide, please. So what we've done since we released the report in 2015 was we charged a subgroup of our original working group with organizing a national summit of healthcare provider groups and health systems, which we held in August of 2016, where we did some pilot testing of some of the tools that have now resulted in the toolkit itself. And at that summit, we got some really helpful feedback from the individuals who participated in that summit, and some ideas about how to help implement the recommended actions in the primary care settings. And this webinar is one example of one of the recommended actions that were suggested at that summit to disseminate the results of the work group. Then in the ensuing several months, and then early into 2017, the AER toolkit was developed, And now we're in the process of broadly disseminating the KAER toolkit to spur increase in cognitive impairment detection and dementia diagnosis by primary care and other healthcare providers. So that's really kind of the brief history and the reason why we have gotten to the point that we are now with the toolkit. So at this time, I'm going to turn it back to Karen. Thank you very much for your attention.
Thank you very much, Dr. Fortinsky. You can mute your phone now until the question and answer session. Next up is Katie Maslow, who will discuss what's in the kit and how it may be used.
Thank you, Karen. So the purpose of the GSA KAER toolkit is to assist primary care providers, which we refer to as PCPs throughout, in implementing the 4 steps in the KAER model. And Rick just showed you this model. And again, just to emphasize the outcomes here that we're looking for and expecting through the use of the model are patient and family well-being and positive health-related outcomes. So we're looking at the kickstarting step, assessment, and diagnostic evaluation and referral as important in achieving those goals. The toolkit contains many different kinds of documents and intended to assist PCPs. As you can see here, there are assessment instruments, there is discussion of various approaches in using them, and other tools. So there are lists of signs and symptoms of cognitive impairment. There are a number of brief cognitive tests, structured assessment instruments, key messages that PCPs could use in talking with older adults and families about cognition, cognitive impairment, and dementia. There are videos showing the processes that are discussed in the toolkit. And there are online materials that PCPs may want to call to the attention of their older adult patients and patients' families. Those are materials that they may either hand to the person or the family member, or print out ahead of time, or give them the URL for the materials. The kit has links throughout to the original documents that are shown in the kit, and each letter is color-coded throughout the kit in order to try to make it easy for PCPs to find materials that they need. The toolkit is intended to provide options to accommodate PCP preferences and procedures that they're currently using, and different practice settings. So clearly, PCPs may already be using some of these tools, and they may prefer to continue to use particular approaches or assessment instruments, diagnostic protocols, ways of making referrals. In addition, PCPs in various practice settings, those who are in an individual PCP office, group practices, health plans, healthcare systems, will have different needs and requirements in terms of which approaches and tools will fit best. And those practice settings may also have procedures or rules about that will make decisions more obvious about which approaches and tools should be used. So again, the toolkit isn't a sort of lockstep set of procedures to follow. Rather, it's procedures and tools and associated approaches that will help PCPs with these different tasks, but can be adjusted to fit their previous work and their setting. So this is the front of the toolkit, and you can see there the 4-step process. I'm not going to read it again, but the toolkit is broken down in sections to represent K, A, E, and R, and has the different each of those sections has the purposes that Rick talked about before. I'm just going to go quickly over these next slides, which talk about, show you what's in each section and give examples of some of the tools and approaches and procedures that are covered. So as Karen said earlier, this toolkit is available on the website of the Gerontological Society of America. We hope you'll use it. It's free, and so this is just, again, to give you an idea of what it contains. So the introduction shows the KAER model, which we've shown you, and talks about the objectives and components of the toolkit. It gives some general tips about how to communicate with older adults in general, some definitions, and some information about the appendices. The step one, the Kickstart section, talks about having brain health conversations with patients and caregivers. As Rick said earlier, we think this is extremely important, and we think from our previous work that it's not happening very much. So the idea here, and discussed in the overview of this section, is that if physicians raise this topic with their patients, it gives the patients, and if a family member is with them, the family member, the idea that this is an important topic. This is something a physician is ready to hear, ready to talk about with them. Physicians can also, and we'll go on and look at the tools. Okay, so the patient group, as you can see here, is people who have no memory or other cognition-related concerns, or at least they're not expressing those concerns at the time that they're in the office. And there have been no changes clinically since the last office visit. The approaches, first is, and you can see the arrow, is raise the topic of brain health. Then other ideas that PCPs might choose to use, and these are options, but they are ask about memory and cognition and concerns. Listen for older adults' concerns about their memory and cognition, and respond. Likewise, listen to family members' concerns about the older adult's memory and cognition. Observe for signs and symptoms of cognitive impairment. This is something that a PCP can do. It's also something that other office staff can do, and we'll talk a little bit more about that later. We think that PCP practices that use a health risk questionnaire, and many do, and the number is increasing, could add a question about memory or cognition to that questionnaire. And there are also algorithms that are proposed to use information that PCPs already have about health conditions and functioning of their patients from existing records. Use those algorithms to indicate which individuals may be at risk for cognitive impairment. This is a slide that shows you some of the materials that are available for physicians to use about brain health and brain aging. We found, as we were working on the toolkit, many excellent materials in this area that are not necessarily being used now by PCPs, but there was an Institute of Medicine study on cognitive aging that was put out in 2015 and included some excellent materials for PCPs, healthcare providers, but also for individuals and families. This is an example of a document that could be printed out and handed to a family if the PCP wants to do that. So in the appendix to this first section, there are, as I said, those two guides, which come from the Institute of Medicine. There are other print materials, there are online materials. As you can see, some of these materials are available in Spanish. And there is also a letter that PCPs might want to use to ask their patients before the patients come in for an annual wellness visit if they have concerns about their cognition. And lastly, a clinician fact sheet. This is the action guide for healthcare providers. I'm certainly not going to read this to you, but if you haven't seen it, you might like to go online and download it and look at it yourself. I think these are excellent materials that, again, PCPs may not be aware of. The second step, assess for cognitive impairment. The patient group here is a group of individuals, older adults, who express, or their family member expresses, concern about memory or cognition, has expressed those concerns to the PCP, or the PCP notices changes in the patient since the last office visit. PCPs should then initiate a process immediately, which would be to use a brief cognitive status test to assess for cognitive impairment and then determine if the test performance indicates impairment. This step, again, this is a way in which the toolkit is adaptable to the preferences and beliefs of physicians about how to proceed. So, as you know, many experts believe that the best thing to do with older adults is a routine use of a brief cognitive test, generally referred to as screening, whether or not cognitive impairment is detected. The KAER toolkit suggests first the kickstarting of the conversation and looking for concerns from family members and others, but the toolkit has a discussion in this section about pros and cons that PCPs might consider in thinking about whether to go more quickly to the brief cognitive test. This section also talks about using a brief family questionnaire to obtain family members' perception of the older adult's cognition. Family members are often aware of early signs before others are aware. And it's also possible to use a brief self-report questionnaire, especially for people who are very early stage of cognitive problems. So you can see there the assessment instruments that are actually included in the toolkit. So mini-cog, GP-cog, memory impairment screen, the different 3 tools that are family caregiver assessment instruments, and 3 tools that are for self-assessment. The toolkit also provides information about how additional instruments, brief assessment instruments, can be found. These are instruments, especially the first 3, the brief cognitive tests, that were selected by the GSA Workgroup as a good idea for the annual wellness visit. So based on the And again, this is at PCP's discretion. Some may skip that brief cognitive test that I just talked about. So skip the A step and go directly from concerns of the patient and the family or the family to a diagnostic evaluation. The KAER toolkit recommends the assessment in between, the brief cognitive assessment in between, but people, physicians, others have strong feelings about this question of the order and the use of a brief cognitive test for screening purposes. So again, the toolkit is adaptable to provide them information and approaches to do whichever they choose. So this step of evaluating for dementia is initiated when there is a cognitive test result that indicates cognitive impairment or concern and the physician's decision to move ahead. It can be initiated after discussion of the cognitive test results with the patient and the family member where that's appropriate, or at least with discussion with the person and the family about why a diagnostic evaluation is needed. So first step, rule out any known reversible causes of cognitive impairment. Then PCPs are urged in the toolkit, if they are adequately trained and experienced, and if they feel comfortable moving ahead with a diagnostic workup, to do that. Alternatively, or at any point during the diagnostic workup, and the toolkit talks about many specific points at which a primary care provider might decide to refer to a specialist or a specialist team that has expertise in dementia diagnosis. So the approaches, the 5 approaches there: conduct a diagnostic evaluation, that is for dementia, identify the causes of diagnosed dementia. The toolkit emphasizes the need to go beyond just the general diagnosis of dementia to find the etiology, the causes of the dementia. Then document the dementia diagnosis and identified causes. That's not always happening now. Disclose the diagnosis and causes to the older adult and family. And then, I'll say more about this in a minute, but PCPs can help this process a lot by trying to help the older adult and family understand the importance of diagnostic evaluation, what will come of it. So there are tools in the toolkit that can be used, talking points and things that can be given to the person or family. Here you can see tools that are included for diagnostic evaluation. So most of the tools there you'll see are assessment instruments, which you are probably familiar with. They, again, provide options for PCPs about which one they prefer, and there is discussion about other such documents in case a PCP is using something else. There are also in this list various documents talking about, for example, differentiating dementias, commonly used ICD-10 codes for the different causes of dementia. A document about disclosure, and as I said before, materials to use, talking points and or hand to the patient or the family about the benefits of early diagnosis. The toolkit makes a strong distinction between detection and diagnosis. It is obvious, and we had discussion about this in the work group, that as everyone, PCPs, patients, families, become more aware of these brief cognitive tests, it can be assumed that a score that shows cognitive impairment or suggests cognitive impairment on one of those tests is sufficient as a diagnosis of dementia. It's essential that patients and families understand that that is not true and that they need to follow up with a full diagnostic workup in order to understand what's causing the cognitive impairment. And some of you may have seen studies recently that show that many patients who are actually told by their primary care physician to follow up, come in for another visit for a diagnostic evaluation, or go to a specialist, don't do that. The numbers are high, half or higher in the studies that I'm citing. So this is an important issue for PCPs to understand and to help with. This last step, refer for community resources. As Rick said, this is very important. It is for patients with any dementia diagnosis. Strongly also encouraged for patients with detected cognitive impairment who do not yet have a diagnosis. And once there is a diagnosis, the toolkit recommends beginning this process. So, the Medicare has recently, at the beginning of the year, added a new billing code, which provides reimbursement to clinicians for care planning services for individuals with cognitive impairment. And this slide shows the clinicians that can be reimbursed under the code. As you can see, not just physicians, but physician assistants, nurse practitioners, clinical nurse specialists, certified nurse midwives. It lists the Medicare beneficiaries who are eligible for, whose physicians are eligible for payment under the billing code. This next slide talks about how often care planning can be provided, showing no restrictions on how often clinicians can provide and bill, and that such an updated care planning process should be conducted at least once a year. And clinicians should review their local Medicare coverage policies for billing limitations for this code. And luckily, with the wisdom of CMS and its advisors, caregivers are included in this code. So the code includes identification of the caregiver as well as an assessment of that caregiver's knowledge, needs, and ability to provide care. The caregiver, I'm just looking at this last bullet, the caregivers can be included throughout each of the required service elements, including involvement in the care planning process. These are approaches for referring for community resources. So the toolkit differentiates between PCPs who are in an organization that has procedures in place for a care management office or other procedures in place for helping high-risk patients or older adults to access help that they need. Differentiating those PCPs from those who do not have that luxury of an organization with a care management or similar program, how those PCPs can refer patients and families to providers in the community that can help. The tools, I'm jumping down a little bit, for this session, for this part of the toolkit, the tools include a template for PCP referrals to community and regional agencies. So that is for this category of PCPs that do not have a care manager in their larger organization whose responsibility is to do these kinds of referrals. The template can be used by a PCP, much more likely someone else in the office, to create a list of community and regional agencies and providers that the PCP then can have in hand to refer patients and family members for further identification of needs and to access help. In addition, other approaches, the toolkit has a list of online resources with URLs given so that PCPs can refer their patients and families to relevant resources or can print those resources out for the patient and family. And the last approach then is to provide general information and encourage participation in clinical trials. The other tools, besides the template, which I talked about earlier, are different models that are in place, models and assessment processes that are in place in various parts of the country. They are models that could be available in the PCP's area for policymakers, agencies, state and community level organizations. And these different tools offer ideas about how they might encourage better linkage between the PCP and the community resources that are available. So Al's Direct Connect, it's an Alzheimer's Association originated project that is now available in other places, that is a way that PCPs can connect directly to a community agency to make a referral. And I'm not going to talk about each of these, but these tools are very impressive and helpful. They are not intended necessarily for PCPs to use, but rather for PCPs to be aware of, and anybody that's interested in improving access to the community and to community resources to consider. So again, desired outcomes, that the person, the older adult and the family well-being is increased through this process, and positive health-related outcomes occur. As Rick said when he started, detection of cognitive impairment, diagnosis, documentation of cognitive impairment and dementia in the person's medical record are essential. They are essential for that person to receive appropriate medical care. As both of us have emphasized, they are essential for appropriate home and community-based services. And we think the best way for people with dementia and their families to get to their own desired outcomes. Here are lists for the person with dementia and the family caregiver of desired outcomes. So you can see there symptom improvement, allowing better function and participation, the coordinated care planning. Persons with dementia, as you know, and families are often upset about the difficulty of navigating the healthcare environment and the community care environment. So we believe that the toolkit can help with that, and that these outcomes are important. Ultimately, one hopes for fewer ED visits and hospitalizations, avoiding unnecessary nursing home placement, and you can see the outcomes, the desired outcomes for family caregivers there. So if PCP was looking at the toolkit, or anyone is interested in looking at it and considering whether to encourage PCPs to use it, here are some questions that the PCP might consider. What level of satisfaction do I have with the current way my practice detects and diagnoses cognitive impairment? What would be a better way? Do I have an action plan for moving toward that better way? And if there is resistance to changing the way that practice handles detection and diagnosis of cognitive impairment, what are the causes of those problems? Some first steps in an action plan you can see here, just taking the pieces of the KAER model. How might the PCP kickstart the conversation? What tools in the toolkit might be useful? How might I assess whether my older adult patient is symptomatic? And how the PCP would evaluate, would either conduct the diagnostic workup or refer for it, and then refer for community resources.
And for some next steps with the toolkit, and if you go onto the website, you can sign up to get the ongoing updates for the toolkit. It's at the bottom of the landing page. Just put your email address in and your name. We are at GSA committed to keeping the toolkit current. We encourage you to share with us any new tools or resources and your experiences so we can incorporate them into the updates of the toolkit. As this kit has just launched about 6 months ago, we're still in the early phases of learning how people are using the kit and wanting to explore ways in which we can share those experiences with others. My email address is right there at ktracy@geron.org. So thank you very much, Katie and Dr. Fortinsky. On behalf of GSA, thank you for your presentations and for your tremendous commitment to our work group and to the development of this very meaningful toolkit. I also thank Merck for their independent grant to develop and conduct this program. Just a reminder that we are recording this session, and you will be sent the slides and an access link via email once the recording is available. Before we move to the question and discussion portion of the session, please know that a webinar survey will be sent to you after the program. In an effort for continual improvement, we'd like to hear your thoughts. And on that survey, please share with me any experiences or thoughts that you have for improvements to the kit. Now we are moving along to our question and answer session. You can type and send your question using the questions feature in the dashboard accessible on the right-hand side of your screen. We will not be using the raised hand feature today, so if you have a question, be sure to use the questions panel. Our speakers will do their best to address as many questions as possible with the time remaining. Rick, please unmute your phone now so I can have the questions be asked. The first question that I have is, what if doctors don't have time to do all of this work in their busy practice? Rick, how would you answer that question to our attendees?
Well, doctors don't have to be the only ones in a primary care group to do this work. They oftentimes do have nurses working in the office with them. If they are part of a physician group or a health system that has an accountable care organization, for example, or a patient-centered medical home, which more and more primary care groups have, then it's almost a certainty at this point that they've hired other providers to support the work that the physicians do, such as nurse practitioners and physician assistants, for example. So any of them, any of those types of providers could be trained to use, to conduct the assessments. Again, the toolkit includes not only the assessment tools, but for many of the tools, instructions on how to use them. So doctors should not feel that they're the ones alone who have to do this kind of work. And but what is important though is that doctors are particularly important in that kickstarting phase. I think that that most doctors, in order to break the ice about talking about brain health, really should be the ones to at least incorporate a question about brain health really as part of a review of systems that they're doing as part of an office visit. So physicians should really do the K piece as part of the general physical exam. Not to do a physical exam, but just in terms of a review of systems and to introduce the area of brain health. But there could be other members of their primary care team who could do the assessments that we talk about in the toolkit.
Katie?
I would just add to what Rick said. As he said, the toolkit discusses the role of non-physician care providers in a medical setting or physician practice. But Rick and I just finished an article that will be in the Gerontologist in a special issue in February, talking about using the KAER model as a way to coordinate the work of non-physician community providers in doing these same tasks. So that is detection of cognitive impairment, assessment. Non-physicians can't do diagnosis, but certainly in referrals. So that is the way to coordinate the work of the community non-physician providers with physicians. And we're excited about that idea. We think that it can result in better, faster movement toward detection of cognitive impairment and diagnosis of dementia, and then that the referrals that get made will be more in a coordinated and connected way to those same community providers.
Thank you, Rick and Katie. We do have a question from the audience concerning communicating with older adults. Do we have any tips on how to promote positive patient outcomes and reactions when you're communicating with the patient with a diagnosis of Alzheimer's disease?
Definitely, yes. In the introduction section of the toolkit, there are some materials, a handout on that topic. But the entire toolkit is designed to provide tips, talking points. There are videos showing physicians doing these different steps, all with the purpose of helping physicians to communicate effectively with their older adult patients and families around this issue that's tricky, touchy for some people.
And I think we have time for just one more question, Dr. Fortitsky and Katie, and it's what if patients are worried well? If they don't have any symptoms, but they know that dementia is in their family history, how should you handle that situation? Or how should does the kit handle that situation?
Right, so I think that this will be an increasingly large number of patients who come in worried well for a whole variety of reasons. The short answer is this is a perfect time to talk about the K step because there's cognitive changes that occur with aging for most people, and that has to be differentiated from possible brain pathology that could lead to dementia, for example. And it's just really important for physicians to get a good history when a patient comes in as far as being worried well, and just to find out exactly what's at the root of their worry. If it's family history, for example, then it would be worthwhile for the physician to delve much more deeply into, well, what exactly is the family history, for example. The worried well population will probably continue to increase. As far as what we offer in the toolkit right now, the tools that are available in the K step really are the most important ones for the worried well at this time.
Great. Well, thank you, Dr. Fortinsky, and thank you, Katie, again. Unfortunately, we are at the end of our time. If anybody who's listening has additional questions, please contact me via email at ktracy@geron.org or include your question in the webinar survey, and we will try to get them answered. This is the end of the program. Please look for the email with the survey on this webinar. We appreciate your participation. You may disconnect now.